കിട്ടുന്നത് 3775 ഡെത്ത് ഇന്ത്യയിൽ നടന്നിട്ടുണ്ട്. അപ്പോ ഈ ഒരു കാലഘട്ടത്തിൽ മാർച്ച് മുതൽ ഏപ്രിൽ വരെയുള്ള കാലഘട്ടത്തിലാണ് നമുക്ക് ഏറ്റവും കൂടുതൽ ഹീറ്റ് വേവ് ഉണ്ടാകുന്നത്. അപ്പൊ ഈ ഒരു CME നമുക്ക് എല്ലാവർക്കും ഒന്ന് മ്യൂട്ട് ചെയ്യോ? ഓക്കെ, സക്കീർ ഒന്ന് മ്യൂട്ട് ചെയ്യോ? സക്കീർ താമരശ്ശേരി
മ്യൂട്ട് ചെയ്യോ?
ഓക്കെ. അപ്പൊ നമുക്ക് 3775 ഡെത്ത് ആണ് 2015 മുതൽ 2019 വരെ മാർച്ച് ടു ജൂലൈയില് ഡെത്ത് ഇന്ത്യയിൽ നടന്നിട്ടുണ്ട്. അപ്പൊ ഇതിന്റെ ഇമ്പോർട്ടൻസ് നമുക്ക് എന്തായാലും അറിയാം. അപ്പം ഹീറ്റ് വേവിന്റെ ഉണ്ടാകുന്ന ഈ ഒരു പീരീഡില് ഇത്തരത്തിലുള്ള CME നമുക്ക് എത്രയായാലും നമുക്ക് അത് ഉപകാരപ്പെടും, എന്തായാലും നന്നാവും എന്നുള്ള പ്രതീക്ഷയോടുകൂടി ഞാൻ ഇദ്ദേഹത്തിന് നമ്മുടെ സക്കീർ ഹുസൈൻ എ, physician, Baluseri Taluk Hospital. Please welcome Sakkir Hussain.
Thank you, sir.
Over to Sakkir.
Okay. Clear?
Yeah.
Screen share ചെയ്തോളൂ.
Okay. Clear ആണ്. Hello?
Yes, clear.
Dr. Vipin?
Yes, it's clear.
Okay. Dr. Sakkir Hussain, Taluk Hospital, Baluseri. നേരത്തെ ഷാജി സാറ് പറഞ്ഞ പോലെ സ്റ്റാറ്റിസ്റ്റിക്സ് സാറ് പറഞ്ഞു, ഈ ഒരു പീരീഡിൽ ഒരു ധാരാളം ഡെത്ത്, മോർബിഡിറ്റി ആൻഡ് മോർട്ടാലിറ്റി ഈ ഹീറ്റ് റിലേറ്റഡ് അസുഖങ്ങൾ കാരണം അല്ലെങ്കിൽ ഹീറ്റ് സ്ട്രോക്ക് കാരണം ഉണ്ടാകുന്നുണ്ട്. അപ്പോൾ അതിൻ്റെ ഒരു ഇമ്പോർട്ടൻസ് നമ്മൾ തിരിച്ചറിയുകയും അതിന് വേണ്ട പ്രിക്കോഷൻസ് അല്ലെങ്കിൽ അതിൻ്റെ ഒരു പ്രിപ്പയർഡ്നെസ് നമ്മൾ ഉണ്ടാക്കിയെടുക്കുകയും വേണം. അപ്പോൾ അതിലേക്കുള്ള ഒരു സെൻസിറ്റൈസേഷൻ എന്ന രീതിയിലാണ് ഈ ഒരു പ്രസന്റേഷൻ പ്ലാൻ ചെയ്തിരിക്കുന്നത്. ഓക്കെ, നമ്മൾ ഈ ഒരു ഹാഫ് ആൻ അവർ ഡിസ്കഷനിൽ പ്രധാനമായിട്ടും ഹീറ്റ് റിലേറ്റഡ് ആയിട്ടുള്ള കോമൺ കണ്ടീഷൻസ്, പിന്നെ അതിൻ്റെ മെഡിക്കൽ എമർജൻസീസ്, ഹൗ ടു ഡീൽ ഇൻ എ പ്രൈമറി ഹെൽത്ത് സെന്റർ ആൻഡ് ദെൻ ഇൻ എ സെക്കൻഡറി ഓർ ടെർഷ്യറി കെയർ സെന്റർ എന്ന ഒരു ആസ്പെക്ട് ആണ് സ്ട്രെസ് ചെയ്യാൻ പോകുന്നത്. ഓക്കെ, actually this heat-related emergencies അല്ലെങ്കിൽ heat-related syndromes ranges from minor heat emergency syndromes to the fatal heat stroke. The minor issues include the heat edema, prickly heat, heat syncope, hyperventilation technique. These are the minor problems, and the severe problems like heat exhaustion and heat stroke also occurs. So before going to the details, we can just remind our basics. The normal body temperature, as all know, oral temperature is 36.8 plus or minus 0.4 degrees centigrade. Now we are using mainly this sensors, temporal sensors. So what is the relation between oral temperature and this temporal sensors? That is, the we are measuring using this sensor. It is usually 0.3 degrees centigrade less than oral temperature. So we can add 0.3 to the value. Then when we call it a fever, if the temperature is in the AM, it's more than 37.2 degrees centigrade, and in the evening it is more than 37.7 degrees centigrade. Then we just feel. Then we should know there is a normal daily temperature.
Please mute.
The normal body.
Okay, Sakkir, proceed.
Normal daily temperature variation is 0.5 degrees centigrade. Then rectal temperature is 0.4 degrees centigrade higher than oral temperature. So we should know the core temperature. We are measuring the core temperature for this purpose. That is, during the management of hypothermia, we are measuring the core temperature. The rectal temperature is taken as core temperature. So if we are using these sensors, then we have to add 0.7 degrees centigrade to the value to get the rectal temperature. 0.7, that is 0.3 plus 0.4, that is we have to add 0.7 degrees centigrade to the obtained value. Then we should know some basics regarding the thermoregulation, how it is happening in our body. That is, every person has a heat load, that is the metabolic heat production, that is from the liver and metabolic processes, and the environmental heat absorption, that is usually balanced by a variety of heat dissipation mechanisms. That is, the heat losing mechanisms are there, which include the evaporation, radiation, conduction, and convection. The evaporation means during sweating, there is a latent heat of vaporization is produced, that is lost. So if the temperature outside is very high, the evaporation process happens, and that will help to lose the heat. The next thing is the radiation. There is an electromagnetic radiation from everyone's body, that is to the surrounding environment. Like that way, also heat is lost. Then another method is conduction. Very little, very few percentage, 2 to 3%, due to the direct physical contact, we are losing heat. Then another method is the loss of heat by air currents, that is convection. These are the 4 methods by which we are losing heat. Now we should know the term what is acclimatization to heat. That is, when a person is exposed to heat for a long time, or there is some sort of physiological changes happen in his body. That is, he can sweat profusely, like he can sweat like 1 liter per hour, something like that, and his sweat contains little amount of sodium. That is some changes that is happening to counteract the heat stress. Such things are happening in our body. So these are the basic things. Now, who are at risk of developing this heat-related illness? You all know the extremes of age, like neonates and older age. Then the pre-adolescents and teenagers, because they don't know the consequences. They come out for playing, exercising, etc. Then there are certain diseases which may reduce the ability to lose heat, like some skin disorders, then cardiovascular disorders and neurological disorders. We know that during the sweating, that is, there is vasodilation occurs, that may be not proper in such a conditions. Then there are diseases increasing the heat production, like thyrotoxicosis, delirium tremens, or any diseases which is causing fever. Okay, hypothermia is not equivalent to fever. You all know, in hypothermia, the hypothalamic thermostat is not raised, whereas in fever, the hypothalamic thermostat is raised. Then another person lacking adequate nutrition and access to air conditioned environment, like homeless people, like beggars, they are at high risk. Then those who work honestly in a hot, humid environment. You know, this construction workers, then policemen, firefighters, everyone, they are at high risk. Then those with obesity, lack of acclimatization, and mild depressions. There are certain drugs, that is anticholinergic, phenothiazines, calcium channel blockers, beta blockers, lithium, tricyclic antidepressants, which many patients are taking, may predispose to these heat-related problems. Now we will go to each one. That is the minor problems. We know the heat edema. This is happening due to there is a pitting edema of the hands and feet. Usually, we can see a lot of patients like that. Usually in the elderly patients. Okay, it is due to the cutaneous vasodilation and also due to the interstitial edema fluid. So we have to rule out all other causes before getting to such a diagnosis. But we can diagnose, we should have a suspicion of this during this season. That is heat edema. The symptomatic management is only needed. Then the prickly heat. Everyone knows that is due to this excessive sweating, there is maceration of the stratum corneum. That may lead to the blockage of sweat glands. Then that will lead to some erythematous pleuritic macular papular rash, which may progress to chronic dermatosis or superinfection. For treatment, we have to ask them to bath frequently with cold water and with a gentle scrubbing so that the macerated starting coating may be removed. And we can use calamine, chlorhexidine, or sometimes oral antihistamines are needed. 1% salicylic acid cream may be useful in some cases. Sometimes, if secondary infected, antibiotic may be used. Streptococcus aureus is the most common organisms. Then the heat syncope. Sometimes patient may present with syncopial attacks, that is syncope following exposure to heat stress as a result of peripheral vasodilatation. Before diagnosing such a case, we have to rule out all the other causes, cardiac, CNS, or all other causes should be ruled out. Here, all rehydration is sufficient. Now, hyperventilation technique in heat stress. It usually occurs after a short exposure to excessive hot environment. That is, the patient may present with carpopedal spasm, paresthesia, etc. So, here again, we have to rule out all other causes for hyperventilation or technique. Now, another situation is heat cramps. It can be happens many times. Here, the spasm of muscles, especially the lower extremity and shoulder muscle, following a heavy muscular exertion in a hot environment. Such patients profuse sweatly so that they will take a lot of fluids, mainly isotonic fluid, that may predispose to heat cramps. It is supposed to be due to the relative deficiency or decrease in the sodium and potassium. And the treatment is oral administration of this salt solution like ORS or other lime, etc. may be sufficient. This usually self-limiting and may last for a few minutes or seconds. Now, the most important two conditions, heat exhaustion and the heat stroke. Heat exhaustion, the difference from the heat stroke is there is the thermoregulatory control is maintained in heat exhaustion and there is no CNS dysfunction. That is, with the maintenance of thermoregulatory control and CNS function, then core temperature is more than 40.5 degrees centigrade. These are the two causes, that is the water depletion and sodium depletion will contribute to the heat exhaustion. So it is a minor form of heat stroke and heat exhaustion may progress to heat stroke. Usually the are not. And this is for a viral infection. It is having very symptoms like two types is the water depletion presented thirst, weakness, headache, loss of consciousness, and dark colored urine. Whereas in salt depleted cases, the predominant symptom may be nausea, vomiting, frequent muscle cramps, and dizziness. Usually the symptoms is very non-specific. So we should have a suspicion, or we should, in a epidemiological setting or the time during this period, if a patient presents with such symptoms, we have to be very careful and we should rule out the cause of heat stress. Then during the lab findings, there is universal elevation of hepatic aminotransferase is there. Then urinary sodium and chloride is low in water depletion, whereas in salt depletion, in addition to the above changes, there will be hyponatremia and hypochloremia. So the management of heat exhaustion, if the young patients previously healthy without any lab abnormality, we can only hospital observation, oral rehydration, and IV rehydration is sufficient. We are seeing such patients right now. We are having many patients with such sort of symptoms. They are coming to the hospital with such symptoms. We are giving some fluids, some oral ORS. They will recover after a few hours. Such patients are coming to our OPD also. If the older patient with comorbidities or predisposing factors present, we need IP care with fluid and electrolyte replacement, monitoring, and resuscitation, because this patient may progress to heat stroke later on. Then we should correct the water deficit in a slow way. Half should be corrected in 3 to 6 hours and remaining 6 to 9 hours. Now the heat stroke. What is heat stroke? This is the main topic. This is a medical emergency. So we should know the basics, how to manage it, and how to manage at primary care level, or how to shift the patient, and after what to do when shifting to the secondary or tertiary care level. So the definition. Heat stroke is defined as an elevated core body temperature, usually in excess of 40.5 degrees centigrade, with associated central nervous system dysfunction in the setting of large environmental heat load that cannot be dissipated. That is, body failed to lose heat. It is a potentially fatal condition, around 30% mortality, that require rapid identification and treatment because mostly missed and misdiagnosed. Now, if a patient, we are having patient with fever, usually. If a patient presented with fever with a history of exposure to heat and any CNS dysfunction, we should suspect heat stroke. So, we already discussed who are at risk. Now, there are, according to the occurrence, type of occurrence, there are two types of heat stroke, that is classic or non-exertional heat stroke and exertional heat stroke. This classic heat stroke usually occurs during this period of these heat waves, or like epidemiological link is there, affect individual with a physiologic or anatomic predisposition or underlying chronic medical condition that impairs thermoregulation, prevent removal from the hot environment, or interfere with access to the hydration or attempted cooling. Yeah, usually such cases are seen in older individuals. Then exertional heat stroke, the second type, it generally occurs in young, otherwise healthy individuals who engaged in heavy exercise during periods of high ambient temperature and humidity. Now we can compare both the classic type and exceptional type. Classic type is usually older persons. They are having predisposing health factors, or they are on some medications like anticholinergic, some psychiatric medication, etc. Then usually seen in within of meters stroke. Anhydrosis can be seen in classic stroke patient. That is not the usual scene. Then CNS dysfunction is there. Younger patients, they are healthy. Sporadic cases can happen because there is no, it can feel in every time, not like in heat only. Then diaphoresis is a common feature here. There is no anhydrosis. So then myocardial and hepatic injury is the main clinical manifestations. Like then acute renal failure can occur. DAC may be marked lactic acidosis is there. Rhabdomyolysis can be there in exceptional heat stroke. Then hypoglycemia can occur, hypocalcemia and hyperkalemia may be there. Now, how to diagnose? So we should have a high index of suspicion because a patient presented with fever may not be fever. It can be hypothermia in such a situation during this period, 3 or 4 months. Then the hot, humid environment, then unacclimatized person, maybe some persons during some exams, or some person they are not usually exposed to this sort of sunlight or the outer environment. If they are presenting to the casualty with such symptoms, we have to suspect. Then how to manage? It's the most important thing. In a primary care level or a single physician, a single doctor is there, what to do? So first we have to record the rectal temperature because we need a monitoring, or we should not overshoot the temperature. So we have to maintain in a particular level. So we have to record. Now we are using this temporal sensors. So you can measure them and add 0.7 degrees centigrade to that. Then remove the patient from the heat source. Patient is to the shady area inside the building or to an AC vehicle, etc. We can change the patient from the heat source. Then the cool the patient. That is the most important thing. Don't confuse. Hyperthermia is due to the external heating of the body, not due to the endogenous factors. So if we don't rush into the paracetamol or fluids, we have to cool the patient. That is the most and primary important thing for the patient. We should have a target of 38 degrees. How to cool the patient? So there are certain mechanisms. Warm water mist. That is, we have to spray a warm water around 15 degrees centigrade. Some books say it is 25 degrees centigrade. Water is sprayed over the body, all over the body. Meanwhile, airflow is over the skin is maintained using manually fanning or with an electric fan. That will lead to the evaporative cooling and effective uh, cooling of the body. That is warm water mist. Then simultaneously, we can vigorously massage the skin to prevent the vasoconstriction during the cooling period. Don't use the cold water, because if you are using the cold water, what will happen? The peripheral vasoconstriction and shivering happen. Both will increase the temperature, body temperature. So don't use cold water. Use the warm water. Then ice pack. Where to keep the ice pack? So we have to reduce the core body temperature, not the peripheral body temperature. So we are having large vessels at axilla, neck, and groin. So we have to keep the ice pack only at axilla, neck, and groin, not all over the body. Don't keep the ice pack cover all over the body. That will not harm the patient. That is eye sheet. Do not cover the patient with eye sheet. Use only ice pack in the axilla, neck, and groin. Simultaneously, we can start IV line and start isotonic saline, and also we can give the oxygen 2 liters per minute. Then we will try to shift the patient to the nearby care center or tertiary or secondary or tertiary care center. Then there is a big warning here, that is how to manage dehydration. We should be thorough that not all hypothermic patients are not dehydrated. Patients with hypothermia are at risk of pulmonary edema and fluid overload. So don't rush into the IV fluids. Treat dehydration and hypothermia separately. These are two entities, separate entities. So we should be careful. The treatment of hypothermia is cooling, not the fluid replacement. But fluid replacement is needed with adequate monitoring of urine output and other pulse rate, tachycardia, everything. Now we reach the secondary or tertiary care level. What we have to do? Then continue the cooling measures and monitor the core temperature. Then there is another method, that is cool water immersion, especially for exertional heat stroke. We have to immerse the patient in a cool water for a few minutes. It's a cumbersome procedure. We can't access the patient and monitor the patient is having an arrhythmia or in a sick condition. We can't monitor the patient during the. The advantage is that it can cool the bed very fast. That is, there will be 1 degree decrease 1 minute. Temperature can be cooled very fast. Sometimes during that patient may shiver. Shivering will produce increased temperature. So give chlorpromazine 25 milligram, and meanwhile we can intubate the patient and continue the IV fluid and maintain mean arterial pressure at 60 millimeter of mercury. And if vasopressors are needed, please consider those without much vasoconstriction. Then certainly monitor the serum electrolytes to guide the fluid therapy. So we have to prevent the pulmonary edema during treatment. And sometimes in patient is in shock or cerebral edema, give IV hydrocortisone. Then there is no much evidence, but there are certain trials on giving cold gastric lavage after injection only. You can give IV cold saline or cold gastric lavage. It is preferred in some centers, but there is no much scientific evidence for this. No, we already told that this hyperthermia is not due to internal cause or any pyrogen or endogenous cause. It is due to external cause. So no medication that is going to be effective in management of heat stroke. So if a patient we are suspecting heat stroke, don't rush into the paracetamol. Antipyretics are not effective. Then there are some reports during the efficacy of dantrolene sodium, but it's not confirmed, not given. Sometimes, as a complication, some patient may develop rhabdomyolysis. It has to be managed accordingly. We have to give IVNS, furosemide, mannitol, and sodium bicarbonate. Then, if we are suspecting DIC or coagulation abnormalities, then we have to start heparinase. If the patient survives, there is a 30% chance of mortality. If the patient survives, he needs at least 7 days of bed rest for complete recovery. Now, we should know during this management, or we have to avoid anticholinergics that will prevent this sweating, then alpha-adrenergic antipyretic salicylate and oxycontin. Salicylate may promote this coagulation abnormalities. Acetaminophen may lead to increased this liver damage. Then this is an important thing, that is, we should have a concern of the differentials. That is, the similar presentation can happen with some infectious and non-infectious causes like cerebral malaria, leptospirosis, enteric fever, sepsis in elderly, and venous infection. All this present with high temperature, CNS abnormalities, etc. So we should have any clinical correlation. That is the proper history, epidemiological link, everything should be there. So then another conditions like non-infectious conditions, neuroleptic malignant syndrome, we all know it is a patient on antipsychotic sometimes develop such syndrome, neuroleptic malignant syndrome, the similar presentation. Then malignant hyperthermia with some inhalational anesthetic agents, then serotonin syndrome, thyroid storm, Graves' disease, poisoning, etc. In neuroleptic malignant syndrome and malignant hyperthermia, there will be increased muscle tone. That is a typical feature of the patient, and the other symptoms may be similar. The neuroleptic malignant syndrome and malignant hyperthermia can be differentiated with this associated, the history of drug intake and the age, everything. Now the investigation, one of the most investigations LFT, it is universally elevated in heat stroke. So if the LFT is normal, we have to rule out other causes, think of other diagnosis. Then blood culture and case study may be needed for diagnosing sepsis and meningitis. Then other things, coagulation studies, then electrolytes and RFT for managing the abdominolysis and the fluid replacement. Then we have to correct hypoglycemia promptly. Then rhabdomyolysis should be managed. Then ABG, there is a chance of lactic acidosis, severe lactic acidosis, especially in this exceptional heat stroke. So we should monitor all these things during the management. We have to cool the patient quickly because the morbidity and mortality is directly related to the duration of hypothermia. So how to dispose the patients? We are seeing in our OP, we are seeing patients like with the heat edema, heat syncope, and heat cramps. Everyone are seeing such a patient during this period. So we can care them in an OP basis. And heat exhaustion need IP care because it may progress to heat syncope later on. Then ideally, heat stroke patients should be managed in an ICU setup. Then what are the poor prognostic factors? If the initial temperature is more than 42 degrees centigrade and the history of prolonged duration of hypothermia, then evidence of acute renal failure, massively elevated liver enzyme, and significant hyperkalemia that indicate poor prognosis. The usual mortality is 30%. Okay. Now, the last topic, how to prevent the adverse effect of hot environment. That is the most important. We have to advise the patient while they are coming to our OP with such symptoms. And also we can give a prophylactic advice, those who are working in hot, humid environment and those coming, going out. That is, when we have to avoid exposure to outside environment from 10 a.m. to 5 p.m. Now our government gives the policy of 11 to 3 p.m. So we can protect them. Then keep drinking water regularly. That is, every half an hour, those who are exerting heavily outside, 250 to 300 ml of water, especially with some salted water, ask them to drink such a manner. Every half an hour, 1 or 2 glasses. Then totally they ask them to drink 5 liters of cool water every day. During the acclimatization, we told that the patient can sweat like 1 liter per hour, those who are acclimatized. So ask them to drink more water. Then always carry a bottle of drinking water, as we are all doing. Then check weight loss after a heavy exercise or heavy work. If 2% of body weight loss, drink extra fluid. If it is more than 5% of body weight, the activity should be limited for 1 day. Those who are working outside in a building work, like they ask them to check their body weight regularly if possible. Then use light colored loose permeable clothes in 1 or 2 layers only. That is very important. Then we can wear a bright brimmed hat of light color when going out. Then keep children less than 5 years and elderly more than 65 years away from sun as far as possible. Never leave them in a closed park or in a hot environment. Such mishaps happen several times. Then we can apply a sunscreen, ointment of sun protection factor at least 15 when going out to the sun. Avoid excess alcohol and cocaine. Then sometimes we can acclimatize to the heat by undertaking a gradually increasing intensity of physical exertion in a gradually increasing hot environment for 80 to 100 minutes daily for 10 days to 14 days. So we can adjust with the heat. Now, if we are feeling exhausted or too thirsty, confused or running out, then take a rest, go to a shaded place, drink cool water and seek help. So, in a nutshell, the aim of presentation is to make an awareness regarding the possibility of these heat-related problems and how to understand, how to identify. That is usually a misdiagnosis. So we are missing the diagnosis mostly. So most of the patients coming to us with such symptoms, we should be aware of this possibility and act promptly. Thank you.
Thank you, Sakkir. So the meeting is open for discussions. Anyone can unmute and discuss. Ask questions. Screen share close ചെയ്തേ സക്കീർ.
Hello, Dr. Sakkir Hussain. One doubt. During the heat stroke presentation, you said that there is always a elevation of LFT. Is there any particular reason for that?
Hepatocytes are particularly heat sensitive, so that they will damage very soon. That is the reason described. So, at times the patient is presented with the normal LFT. We have to check for other causes for such presentation. Usually it comes around 5,000, something like that. Very high value may be obtained in heat stroke, severely sick patients. നേരത്തെ ഷാജി സാറ് നമ്മുടെ സ്ട്രാറ്റജിസ്റ്റ് പറഞ്ഞായിരുന്നു. അപ്പോൾ നമ്മുടെ കേസുകളിലും നമ്മുടെ ഒ പികളിലൊക്കെ ഒരുപാട് പേഷ്യൻസ് ഇതുപോലെയുള്ള നോൺ സ്പെസിഫിക് സിംറ്റംസ് ആയിട്ട് വരുന്നുണ്ട്. അപ്പോൾ ഇത്തരം പേഷ്യൻസിനെ മാനേജ് ചെയ്യാനും പലപ്പോഴും ഒരു ഫ്ലൂയിഡൊക്കെ കൊടുത്ത് പേഷ്യന്റ് കുറച്ച് കഴിയുമ്പോഴത്തേക്ക് ഇമ്പ്രൂവ് ചെയ്യും. അപ്പോൾ പലപ്പോഴും ഇത് റിലേറ്റഡ് ടു ദിസ് ഹീറ്റ് ഇൽനെസ്സസ് ആവാം. അപ്പോൾ അത് ഐഡന്റിഫൈ ചെയ്ത് കഴിഞ്ഞാൽ. പിന്നെ മറ്റൊരു കാര്യം, ഈ NCD പേഷ്യൻസ് അല്ലെങ്കിൽ ഒരുപാട് കോമോഡിറ്റീസ് ഉള്ള പേഷ്യൻസ് മൾട്ടിപ്പിൾ ഡ്രഗ്സ് എടുക്കുന്നുണ്ട്. അപ്പം ഈ ആന്റിഹിസ്റ്റമിൻസ് ലൈക്ക് അതുപോലുള്ള സൈക്യാട്രിക് മെഡിക്കേഷൻ, BPM, അപ്പോൾ ഇത്തരം മരുന്നുകൾ എടുക്കുന്ന പേഷ്യൻസിന് നമ്മൾ പ്രത്യേകം നമ്മുടെ ഒരു റൂട്ടീൻ കൗൺസിലിംഗിൽ ഈ ഒരു ആസ്പെക്റ്റും കൂടെ ഹീറ്റ് സ്ട്രോക്ക് റിലേറ്റഡ് ആയിട്ടുള്ള കാര്യങ്ങൾ അല്ലെങ്കിൽ ഹീറ്റ് റിലേറ്റഡ് ഇൽനെസിന്റെ ഒരു അവയർനെസ് അവർക്കും കൂടി നമ്മൾ ക്രിയേറ്റ് ചെയ്യാൻ ശ്രമിക്കണം. കാരണം ഈ ഡ്രഗ് ഇൻഡ്യൂസ്ഡ് പ്രിഡിസ്പോസിഷൻ വളരെ കൂടുതലായിട്ട് ഉള്ളതായിട്ടാണ് റിപ്പോർട്ട് ചെയ്യപ്പെടുന്നത്. പിന്നെ മറ്റൊരു കാര്യം, പ്ലെയിൻ വാട്ടർ കുടിക്കുന്ന കാര്യം. അതായത് പ്ലെയിൻ വാട്ടർ, അതായത് കുടിക്കുന്നതിന് പകരം കുറച്ച് സാൾട്ടഡ് വാട്ടർ ആയിരിക്കും പലപ്പോഴും കൂടുതൽ അനുയോജ്യമായിരിക്കുക പേഷ്യൻസിന്. അപ്പൊ പലരും ഹൈപ്പർ ടെൻഷൻ ആണ്, അപ്പൊ അതുകൊണ്ട് കഴിക്കാൻ പറ്റില്ല എന്നുള്ളൊരു അസംഷൻ ഇരിക്കും. അപ്പൊ അവരെ അതിൻ്റെ ഒരു നീഡ് പ്ലെയിൻ വാട്ടർ അല്ല സാൾട്ടഡ് വാട്ടർ കുടിക്കേണ്ട ഒരു ആവശ്യം നമ്മൾ മനസ്സിലാക്കിയിട്ടുള്ളത്. ഡോക്ടർ പ്രിക്ലി ഹീറ്റില് നമ്മൾ പൗഡർ ഉപയോഗിക്കുന്നതിനെ പറ്റിയുള്ള ഒരു ഡൗട്ട്. ആക്ച്വലി ഇതിന്റെ ഫിസിയോളജിക്കൽ മെത്തേഡ് യൂഷ്വലി അത് സംഭവിക്കുന്നത് ഈ എന്താ മാസറേഷൻ ഓഫ് സ്ട്രാറ്റൻ കോർണിയം, സ്കിന്നില് സ്ട്രാറ്റൻ കോർണിയം എക്സസീവ് സ്വെറ്റിംഗ് കാരണം സ്ട്രാറ്റൻ കോർണിയം മാസറേറ്റഡ് ആവും. സോ അതിന്റെ ഡെബ്രീസ് ഈ ഒരു ഡക്റ്റിൽ പോയിട്ട് ബ്ലോക്ക് ചെയ്യും. ബ്ലോക്ക് ചെയ്യുന്ന സമയത്ത് അവിടെ ലീഷൻസ് ഡെവലപ്പ് ചെയ്യും. അത് സബ്സിക്വന്റ്ലി ഇൻഫെക്റ്റഡ് ആയി സൂപ്പർ ഇൻഫെക്റ്റഡ് ആയിട്ടാണ് ഒരു പത്തോളജി വരുന്നത്. കൂടുതൽ അനുയോജ്യമായ ഒരു ഈ പേഷ്യന്റ് ഈസ് നോട്ട് സെക്കൻഡറി ഇൻഫെക്റ്റഡ്, ഒരു അനുയോജ്യമായ ട്രീറ്റ്മെന്റ് പേഷ്യന്റ് ധാരാളം വെള്ളം കുടിക്കുക, പിന്നെ ഫ്രീക്വന്റ് കൂൾ വാട്ടറിൽ ബാത്ത് ചെയ്യുക, അതിനുശേഷം ഒരു സ്ലൈറ്റ് സ്ക്രബിങ് വേണം. ആ ഒരു മാസ്കുലേറ്ററി സ്കിന്ന് പോകാൻ വേണ്ടിയിട്ട് കുളിക്കുന്ന സമയത്ത് സ്ക്രബ് ചെയ്യുക. പിന്നെ ഇതുപോലുള്ള ടോപ്പിക്കൽ അപ്ലിക്കേഷൻസ് ആണ് സജസ്റ്റ് ചെയ്യുന്നത്. ഐ ഡോണ്ട് നോ ദ എക്സാക്ട് റോൾ ഓഫ് പൗഡർ. ഡെർമറ്റോളജിസ്റ്റ് ഒരു ഒപ്പീനിയൻ പറഞ്ഞാൽ നന്നായിരിക്കും. യെസ്, അനദർ ക്വസ്റ്റ്യൻ, എന്താണ് കൂൾ ഐ വി ഫ്ലൂയിഡ്സ് കൊടുത്താലുള്ള അഡ്വാൻറ്റേജ് ഹീറ്റ് സ്ട്രോക്കിൽ? ഇപ്പോൾ നമുക്കൊരു ഫിക്സഡ് ടെമ്പറേച്ചർ ഇതുണ്ട്, ഓവർ ഷൂട്ട് ചെയ്യാൻ പാടില്ല. ഒരു 38, 39 നമുക്ക് ടെമ്പറേച്ചർ കുറച്ച് കൊണ്ടുവന്നാൽ മതി. സോ ഐ വി ഫ്ലൂയിഡ്സ് കോൾഡ് കൊടുത്തു കഴിഞ്ഞാൽ അത് ഓവർ ഷൂട്ട് ചെയ്യാനുള്ള ചാൻസ് കൂടുതലാണ്. അപ്പോൾ ഈ കാരണം കൊണ്ട് ഇപ്പോഴത്തെ ഒരു ലേറ്റസ്റ്റ് റെക്കമെൻഡേഷൻ പ്രകാരം പേഷ്യൻസിനെ നമുക്ക് മിസ്റ്റ്, അതായത് സ്പ്രേ ചെയ്യുക, എയർ സ്പ്രേ ചെയ്യുക, എന്നിട്ട് ഫാൻ സൈഡിലൂടെ ചെയ്യുക, പ്ലസ് ആക്സിലയിൽ അല്ലെങ്കിൽ ഗ്രോയിനിൽ നെക്കിലൊക്കെ ഐസ് ക്യൂബ് വെക്കുക. ഇതുകൊണ്ട് തന്നെ മറ്റു രീതിയിൽ ഉണ്ടാവുന്ന ഇഫക്റ്റ് നമുക്ക് കിട്ടും. അപ്പോൾ അതാണ് ഐഡിയൽ മെത്തേഡ് എന്നാണ് ഒരു ഗൈഡ് ലൈൻസ് പറയുന്നത്. പിന്നെ ORS കൊടുത്താൽ, അത് നേരത്തെ പറഞ്ഞു, ഹീറ്റ് എക്സോഷൻ അല്ലെങ്കിൽ അതുപോലുള്ള മൈൽഡർ സിംപ്റ്റംസിന് പേഷ്യൻസിന് നമുക്ക് ORS സജസ്റ്റ് ചെയ്യാം. കാരണം പ്ലെയിൻ വാട്ടർ കഴിക്കുന്നതിനേക്കാളും കൂടുതൽ അഡ്വാൻറ്റേജ്, അതായത് സോഡിയം ഒരുപാട് ലോസ് ചെയ്യും. അൺഅക്ലമൈസ്ഡ് ആയ ആൾക്കാരാണെങ്കിൽ എക്സസീവ് സോഡിയം ലോസ് കാണും, പൊട്ടാസ്യം ലോസ് കാണും. അപ്പോൾ അവർക്ക് നമുക്ക് ORS സജസ്റ്റ് ചെയ്യാവുന്നതാണ്. പിന്നീട് മറ്റൊരു പ്രാക്ടിക്കൽ പ്രോബ്ലം ഇതിൽ സൂചിപ്പിക്കാനുള്ളത്, നമ്മുടെ വാർഡുകൾ. അപ്പോൾ ഈ ഒരു സമയത്ത് നമുക്ക് ഒരുപാട് IP പേഷ്യൻസ് ഉണ്ടാവും നമ്മുടെ വാർഡുകളിൽ. അപ്പോൾ പല ഹോസ്പിറ്റലിലെയും ബിൽഡിങ്ങിൽ ഒക്കെയുള്ള ചില പ്രത്യേകതകൾ കാരണം നല്ല ഹോട്ടായിരിക്കും. അപ്പോൾ വാർഡിൽ IP ആയിട്ടുള്ള പേഷ്യൻസിന് പോലും റിസ്ക് കൂടാനുള്ള ചാൻസ് ഉണ്ട്. അപ്പോൾ അവർക്ക് വേണ്ട അപ്രോപ്രിയേറ്റ് മെഷേഴ്സ്, അഡിക്വേറ്റ് ഫ്ലൂയിഡ് നമ്മൾ മുൻകൂട്ടി കണ്ടുകൊണ്ട് പേഷ്യൻസിന് നല്ല ഹോട്ടായിട്ടുള്ള സ്ഥലങ്ങളൊക്കെ ആണെങ്കിൽ ആ രീതിയിൽ IP പേഷ്യൻസിന്റെ കാര്യം ഈ ഒരു റിസ്ക് നമ്മൾ അസസ് ചെയ്യും. അതിനനുസരിച്ച് ഫ്ലൂയിഡ്സ്, ഓറൽ ഫ്ലൂയിഡ്സ്, IV ഫ്ലൂയിഡ്സ് ഒക്കെ കൊടുക്കാൻ വേണ്ടി നമ്മൾ ശ്രമിക്കുകയും വേണം.
ആരോന്ന്
More question? The case management.
There are no more questions. invite
person management ഉണ്ടെങ്കിൽ ഷെയർ ചെയ്താൽ നല്ലതാണ്. എക്സ്പീരിയൻസ് ഫോർ മാനേജിങ് സിറ്റുവേഷൻ.
If there are no more doubts, I invite Dr. Dinesh to propose the vote of thanks.
Thank you, Vipin sir. First of all, I would like to thank Dr. Sakkir Hussain. Actually, this CME, we planned it only very few days back. It was actually on short notice. And the moment we informed him, he was ready to take the